So now let's get started. Our first presenter and speaker is Dr. Ronald Rachel. He's from Borland Groover. Dr. Rachel specializes in diagnosis and treatment of wide spectrum of GI and liver disease, and he's board certified in internal medicine GI, and he's also our transplant hepatologist and my to-go person for liver disease. He's one of our hepatologists, and he's going to talk to us about abnormal LFT and how to start workup as a primary care doctor. So we welcome Dr. Rachel.
Okay, good morning. Yes, I'm Ronald Rachel. I'm a gastroenterologist at Borland Groover. I'm mainly at the Baptist South office. We're going to discuss abnormal liver tests, specifically in the setting of acute hepatocellular and cholestatic liver injury. So our objectives today, we're going to recognize the difference between liver function test and liver injury test, describe the characteristics of hepatocellular, cholestatic, and mixed patterns of liver injury, outline the evaluation of acute hepatocellular and cholestatic liver diseases, and then importantly recognize alarm features that would require hospitalization or urgent referral to a GI specialist. So a couple terms. So we use the term liver function test very commonly and often used to represent liver chemistry or tests such as AST, ALT, alkaline phosphatase, but actually these aren't really true measures of liver function. So liver chemistry abnormalities more specifically reflect hepatocyte or bile duct cell injury, and so we can actually more accurately refer to these as liver injury tests. So true liver function tests reflect liver synthetic and excretory function. So the liver synthesizes plasma proteins, albumin, clotting factors, and the hepatocytes secrete bile into the bile canaliculus. So when we look at the pattern of injury, we're looking at mainly two types, hepatocellular and cholestatic, and then there is a mixed type where you have abnormalities on both. But for hepatocellular injury, we're looking mainly at the aminotransferases, ALT, AST. Normal in general is 40, but you probably all have seen labs from different labs that have a higher upper limit of normal than others. This is based on the reference population, the local population. But it's actually been seen we really should be looking at much lower numbers, like less than 30 for men, less than 19 for women. It's been shown that higher levels, even modest levels, modest elevations of ALT, AST is probably associated with more all-cause morbidity and mortality. So cholestatic disease, the main thing we're looking at is alkaline phosphatase or ALP-PHOS or ALP. Normal is really age-dependent. It's high in periods of growth, bone turnover, pregnancy. And then we have two confirmatory tests, GGT and 5' nucleotidase. Both of these are often used as confirmatory tests when you have just an isolated alkaline phosphatase. So then we look at the abnormalities can further be classified by duration and magnitude. And for this talk, we're mainly focusing on acute, but during your workup, you also want to think about chronic diseases. But when we're talking about acute, it's mainly abrupt. Happen very, very suddenly, less than 6 months in general. Chronic is defined as more than 6 months. When we look at the magnitude, we can say mild, moderate, severe. Mild is generally less than 200 international units, moderate between 200 and 600, and severe would be greater than 600 international units. So this graph is a good kind of representation of that. Different diseases often, kind of cluster as far as like the severity of the abnormalities. So it would be very unusual you see someone with alcoholic liver disease with enzymes in the thousands, 10,000s. Often that means you're probably missing another diagnosis there. So ischemic, toxic liver injury, these are the main things we think about when you see very severe elevations. Then behind that's acute viral hepatitis, autoimmune hepatitis. Those can also cause pretty severe elevations. But patients with cirrhosis, chronic hepatitis generally have low levels of elevation. So you have to keep in mind that the magnitude really doesn't correlate with disease severity. During your workup, also do not forget about the non-hepatic reasons. So muscle injuries such as rhabdomyolysis, dermatomyositis, seizures, patients with history of long-distance running, intense exercise. So labs like CPK, aldolase, LDH, those might be helpful in those situations. Think about thyroid disease, celiac disease, anorexia, and adrenal insufficiency. So the two main tests we really look at, again, these are the ones that we often refer to as the LFTs, but the AST, LFT, more specifically, again, liver injury, so involved in a transfer of amino groups, aspartate, alanine to ketoglutaric acid, and these are our markers of hepatocellular injury. So AST is present in liver, cardiac, muscle, skeletal muscle, kidney, brain, whereas ALT is primarily in the liver. So if you have an isolated elevation of AST, this may be a little bit more suggestive of cardiac or muscle disease, whereas ALT is much more specific for liver injury. So you want to look at the two together. Sometimes it's not wrong that you only order an ALT, but using them together is much more helpful. Next injury test, serum alkaline phosphatase. It's a family of enzymes. Basically, it can come from also a variety of tissues, liver, bone, intestine, placenta, kidneys. And when you see an elevated alkaline phosphatase, this is really the hallmark of cholestasis, but is usually associated with some abnormalities in the transaminases, AST, ALT, and the confirmatory tests. If you do see isolated elevation, that's when you think about, your non-hepatic disorders, and things like Paget's disease. There are isoenzymes, the fractionation. You can order these tests, but just be careful when you order them. It may lead to some more confusion. There is overlap between liver and bone fractions. So I really reserve these cases when you have only isolated alkaline phosphatase and normal confirmatory enzymes. In that situation may be helpful. If you have alkaline phosphatase up to 4 times upper limit of normal, still could be somewhat nonspecific, but generally when it's very high, that's usually associated with cholestasis. Next is serum gamma glutamyl transferase, or GGT. Again, this is a confirmatory test. I wouldn't order it, generally all the time, but just to give you an idea, it is nonspecific. It's present in many cell membrane tissues. You have pretty comparable values in men and women. Newborns have higher values. It does not rise in pregnancy. So you can see it whether you have liver, biliary tract, pancreas disease, alcohol use, and even medications like barbiturates and phenytoin. So just keep in mind, only 1/3 of cases of GGT elevation are actually due to liver disease. So again, use it more as a confirmatory test. Serum 5' nucleotidase, also a confirmatory test. It is seen in, again, a variety of tissues: liver, intestine, brain, heart, blood vessels, pancreas. If you have elevations of alkaline phosphatase, it's usually for the same reasons, 5' nucleotidase. So in cases of cholestasis, infiltrative disease, space-occupying lesions, it does not increase in bone disease. And if you have an elevated alkaline phosphatase and the 5' nucleotidase is not elevated, cholestasis is still not ruled out. So this is a test, honestly, I don't particularly order very often, or really at all. So the GGT is often very helpful up front if you need it. Now the liver function tests, we talked about synthesis and secretory function of the liver. So albumin is a very good marker of function. It's the most abundant blood protein synthesized by the liver. In general, it's preserved in acute disease. So it becomes important when you have someone with chronic liver disease. Their low serum albumin is indicative of the presence of cirrhosis, except in cases where you have protein loss in the urine or stool. PT and INR, so again, the liver is involved in clotting factor production, mainly the factors synthesized by the liver in the vitamin K dependent fashion. So even in acute or chronic disease, the INR, PT and INR can be abnormal. So specifically like bile stasis, you can administer vitamin K to see if it corrects, because vitamin K is liposoluble and needs bile to be absorbed. Whereas if it's from a hepatocellular injury, since the issue is synthetic dysfunction, the IV vitamin K will not correct the abnormality. Bilirubin, so again, this is a measure of function, but actually you can see elevations in both hepatocellular injury and cholestatic injury. So either there's a problem with the secretory function or poor bile flow. If you have mainly elevated direct bilirubin, this is more specific for cholestatic and hepatocellular injury. If you have indirect hyperbilirubinemia, especially if it's isolated, this really indicates the presence of something else like hemolysis or benign Gilbert syndrome. But generally with Gilbert's, we're looking at values less than 6. So this just kind of summarizes what we already talked about. So hepatocellular injury is mainly the elevation of ALT and AST. And there is a equation you can do this, R ratio to C, but in general you look at it, you see it's predominantly ALT, AST. Cholestasis is predominantly alkaline phosphatase. You can have elevated bilirubin again in both. PT can both be prolonged. Again, the difference there in cholestasis is it corrects with IV vitamin K. And then albumin, again, is mainly helpful in patients who are suspecting have chronic disease, so it'll be low in chronic disease. So the etiologies of acute hepatocellular injury, most common would be drug or toxin-induced, viral hepatitis, ischemia, alcohol, and then afterwards, then you start to consider the other things like autoimmune hepatitis or liver disease, acute biliary obstruction, hepatic vein obstruction or Budd-Chiari syndrome, and Wilson disease. This just shows just a little more breakdown of the common drugs and toxins. So again, alcohol, acetaminophen, NSAIDs, antibiotics, antiepileptics, anti-TB drugs, herbal supplements, and then the rare cases like a mushroom causing liver toxicity and failure. For viral hepatitis, we're talking about A through E. In patients that are immunosuppressed, then you can start to think about things like Epstein-Barr, herpes virus, CMV, adenovirus, and for ischemia, it's mainly shock liver and Budd-Chiari. So remember during your workup, again, this talk is mainly acute, but patients can have chronic disease, and you see them for the first time with elevated tests. Just keep in mind that if it's in the thousands, 10,000s, it's probably not from some chronic disease, but don't be surprised if they do have some underlying chronic disease. So I'm talking about NASH, hemochromatosis, PSC, PBC, alpha-1 antitrypsin. These are all things that should really not cause an acute hepatitis. History is very important. So if you're focused mainly on drug-induced liver injury, obtain the history, and within the last 6 months, very important. So even if they started a medicine in the last 6 months, that's still important. Still could cause a presentation later. So ask about over-the-counter supplements, herbals, nutritional, dietary supplements, really anything that they're ingesting. Risk factors for viral hepatitis, you guys all know this: travel, raw or uncooked food, sexual practices, IV drug use, unprofessional tattoos, and occupational exposures. Alcohol, this is sometimes hard to tease out of the patient, but really look for this pattern of either excess use. We kind of generally think about it, 1 drink a day on average for females and 2 for males. But binge drinking is also, harmful. If they have all of that in one sitting, that's still harmful. The blood alcohol levels get very high, so that can be harmful as well. So think about alcohol hepatitis even if their last drink had been several weeks ago. Alcohol levels can often be negative, again, if they haven't drank for some time, but they've had a pattern going on for some time. And then remember, they always either minimize or deny drinking. So you have to have a high index of suspicion there. Risk factors for ischemia, we think about arrhythmia, syncope, hypertension. So in the hospital, we're talking about hemorrhagic shock, septic shock, infection, post-surgery, those types of things. So the initial evaluation, and this is usually on the outpatient setting if you have some borderline mild elevation. So a thorough history and physical, discontinue hepatotoxic medications and alcohol consumption. That's just across the board to eliminate that as a variable. And then assess risk factors for some chronic diseases like viral hepatitis, fatty liver. I generally just order initially CBC, a comprehensive metabolic panel, which includes your AST, ALT, alkaline phosphatase, total bilirubin, albumin. Important to order a PT-INR, and then the viral serologies. Again, iron panel can be done initially, but again, that's mainly for looking for chronic disease. Abdominal ultrasound is a good initial test. It's non-invasive compared to CT, MRI, cheaper. And then if you have persistent elevation, we're talking about maybe even weeks later and your initial workup is negative, and again, it's mild elevation, then you can start to think about the other things like autoimmune disease, so ordering autoimmune markers, and then in the right patient age and populations for alleloplasmin, looking for Wilson disease and alpha-1 antitrypsin. Also during this time, think about again the non-hepatic causes, and then after kind of a secondary workup, if they're still concerned, that's when a liver biopsy can be done. So this is now for like moderate to severe elevation. So these are mainly patients who are going to be seen in the hospital. So all the same stuff, except now you can think about really doing the autoimmune markers up front, ordering a toxicology screen, doing Tylenol levels, again consider ceruloplasmin based on the patient's age, and then still starting with ultrasound. And then now we're talking about hospitalized patients, probably more concerning features. We want to make sure we understand the risk for liver failure and prognostic tests. So ammonia, blood gas, lactate, phosphorus, those are all typically ordered in the inpatient setting. This just breaks it down a little bit more. I mean, we did talk about ordering viral hepatitis, but the other viral viral things you need to think about, particularly if it's a very marked elevation, time is of the essence, you could think about ordering all these things first line, like hepatitis E, Epstein-Barr, herpes, cytomegalovirus. But again, if there's someone that's immunosuppressed, like a transplant patient, that'll increase your level of suspicion more. The autoantibodies there, again, are important, but this, again, is for moderate to severe. So the alarm signs. You'd want to hospitalize the patient if they have prolonged PTINR, altered mental status, encephalopathy, asterixis. These are all concerning features. If they can't tolerate PO, they have signs of systemic inflammatory response, sepsis, or they're just an unreliable patient and you don't think you're going to be able to do a thorough workup with close follow-up. And then anyone with marked elevation of ALT, AST, someone that presents acutely with thousands, 10,000s, even if they're not confused, and it's still very concerning and it can progress quickly over time. So think about hospitalizing that patient. So if no alarm signs, then you can think about the outpatient management, which includes frequent monitoring, office visits. PTINR, again, is very important. If you can get labs twice a week, if they're improving, maybe space that out once a week. But seeing them often is also important, just to assess for things like changes in their mental status. So again, if after non-invasive tests unrevealing, this is again another point where we might consider liver biopsy. So acute liver failure is all the following: acute hepatocellular injury, coagulopathy, so INR greater than 1.5, altered mental status or asterixis, and no pre-existing liver disease. The most common cause will be Tylenol. Almost half the cases are from Tylenol. Even in indeterminate cases, there's a large percentage that probably can be attributed to Tylenol. So these patients are very sick. They often require ICU care. This is where urgent consultation, referral, and transfer to a liver transplant center if possible really should be considered early. Death occurs from multi-organ failure, cerebral edema, infection, sepsis. So again, very sick patients. So you don't want to miss these signs up front. So our first case here, we have a 19-year-old female. She's got a history of depression, was binge drinking at a party. The next day, she had nausea, vomiting, abdominal pain, moody and sleepy. And it's probably going to be brushed off as, she's kind of hungover, so no one was really that worried. But by the third day, she became confused, disoriented, agitated, so friends brought her to the hospital. And her lab showed AST 11,000, ALT 12,000, alkaline phosphatase 200, total bilirubin 2.5, INR 7.5, lactate 5.8, ammonia is elevated 152. The initial viral serologies are negative, autoimmune marker ANA is negative, Tylenol is negative, and her ultrasound of her liver is also completely normal. So this is acute liver failure. We just discussed, marked elevation ALT, coagulopathy, altered mental status. But what's important here is even though the alcohol history is there, these ALT, AST elevations in the 10,000s are very concerning. You'll rarely see that alcohol is the cause of that severe elevation, and AST usually should be less than 300 when we're talking about just purely alcohol-related injury. So acetaminophen overdose was highly suspected based on her history, depression, alcohol intoxication. The rapid time course, the pattern, all this is highly suggestive of acetaminophen toxicity. So she was treated with NAC. NAC was stopped after INR improved, AST improved, and altered mental status resolved. So this is, a good outcome here, but obviously very sick. And initially, if she's not already in the situation to be referred to a transplant center, she really should be as soon as possible. So basically, she recovered with supportive care. So acetaminophen level is often negative, which we saw, so this should never be used to rule out the diagnosis. You need to have a high degree of suspicion to make the diagnosis, and when in doubt, in the hospital setting, it's in general, low risk to start NAC. Again, most indeterminate, or not most, but a lot of indeterminate cases are probably related to Tylenol. NAC is effective early, but there's still improved survival even if you think about it later, 48 hours after ingestion. So with aggressive supportive care, acetaminophen-induced acute liver failure has a relatively high rate of spontaneous survival. The next case, we have a 35-year-old female. She's got 2 days of nausea, vomiting, abdominal pain. Friends say she looks yellow. She does take ibuprofen, but denies any acetaminophen use and denies alcohol use. So her labs, her AST is 200, ALT is 100, alkaline phosphatase 230. She has pretty high total direct bilirubin, 16, 13. PT and INR may be slightly elevated, 12.1, 1.2. She's got leukocytosis, 20, platelet counts 300. Her serum alcohol is positive, and her ultrasound shows hepatomegaly and an echogenic liver. So you ask her more about this, and there are not always easy ways, to ask about this, but she eventually admits, yes, she does drink alcohol. She drinks up to a fifth of vodka, and over the last several weeks, she's been drinking more. So based on the history, the pattern, the clinical presentation, this looks really like acute alcohol hepatitis. So the fever, abdominal pain, jaundice, leukocytosis, hepatomegaly, moderate AST elevation, and then the ratio where ALT ratio is greater than 2. Because it can look like sepsis, these are patients you obviously want to, in the hospitalization, you're looking for signs of infection, but also these are typical signs you see just in alcohol hepatitis alone. Her discriminant function is 9. This is a measure of basically using the bilirubin PT-INR. The higher it is, really, the more severe the disease is. So in cases where it's severe, greater than 32, associated with high mortality, and at this point, the only thing we have to offer is a trial of prednisone. But in this case, it's non-severe. It's managed with supportive care, nutritional support, watching for alcohol withdrawal, all those kinds of things, and the patient recovers spontaneously. So think about for alcohol hepatitis, it's typically like an acute on chronic injury. Actually, maybe half the patients that present like this probably already have cirrhosis. The history usually is there of some excess use or binge drinking. Again, the ratio is important, AST, ALT ratio greater than 2 to 1, and then only sort of modest elevations in AST, generally less than 300. GGT can be elevated as well. Just remember, even after, if their last drink has been several weeks ago, they can still present acutely later on. And drug test or serum and urine alcohol tests may be negative. And then remember, again, the patients often minimize or even deny alcohol use. Next case, we have a 50-year-old Japanese female. She's got a history of stage 2 breast cancer. She's treated with doxorubicin, cyclophosphamide. Initial ALT is normal, it's 20. So she starts chemotherapy, ALT increases to 40, then it increases to 110. Drug-induced liver injury is suspected. She looks well, no jaundice, no changes in mental status. INR is 1, so basically it's just followed closely. You see here, there then is a rapid progression in enzyme elevation up to the 3,000 range and INR elevated up to 2.0. So at this point, she's admitted to the hospital. Viral hepatitis serology, so positive Hep B surface antigen, positive Hep B core, antibodies positive, autoimmune markers negative, and abdominal ultrasound is unremarkable. This is further down the course. She's admitted to the hospital. She becomes confused. The INR continues to elevate. Transaminases continue to elevate. Bilirubin's elevated. And then she has a positive, very high viremia HBV DNA, greater than 1 billion. So this is an interesting case. It's a chemotherapy-induced reactivation of chronic hepatitis B. So despite starting treatment at this time point, she didn't improve. And because of the active breast cancer, she's not a candidate for liver transplant. So unfortunately, this is a sad case. She dies of multi-system organ failure. So again, this is acute liver failure. what's interesting about this is, so previously we defined there should be no pre-existing liver disease, but this is one of the exceptions. She actually had, chronic hepatitis B, or was exposed in the past and had high-risk chemotherapy and had reactivation. So she had some pre-existing liver disease. Alarm signs require immediate hospitalization. We talked about that, elevated INR, changes in mental status. So Hep B reactivation in the setting of chemotherapy is preventable. So these patients should be screened. Prophylactic antiviral therapy is started at the onset of chemotherapy, and for high-risk patients is continued even a year after finishing chemotherapy. Acute liver failure due to drug-induced liver injury other than Tylenol is usually a much worse prognosis, and many don't survive without liver transplant. Okay, so we're change gears a little bit. We're going now to the cholestatic diseases. So cholestasis basically is a lack of normal bile flow, and this can occur at different segments. So the smallest ducts in the intrahepatic liver, or within the liver, down to the larger ducts in the perihilar area, and then the largest ducts in the extrahepatic area, which can be affected by structures in that area like the pancreas and small bowel. So in general, again, we're talking about patients that present within the first 6 months. Often we're seeing these patients, acute elevations within days. The mechanism can be multiple. Hepatocellular derangement can cause impairment of bile conjugation, but if you have actual damage to the ducts, you can have impairment of bile flow. And then non-hepatic reasons would be hemolysis, Gilbert syndrome. So the labs again, this is just a reminder here, alkaline phosphatase is the main test we're looking at. And again, it's not going to be elevated necessarily always by itself. You want to look for that coexistence with a high bilirubin, high AST, ALT, but the pattern is just the alkaline phosphatase is going to be the predominant elevation in cases of cholestasis. And then you have your confirmatory enzymes that you can use as well. When you have isolated hyperbilirubinemia, think about other things than cholestasis. So if it's mainly indirect, again, Gilbert's or hemolysis, and then if you have an isolated direct, you can see this in sick patients with sepsis or congenital diseases like Dubin-Johnson. The most common etiologies for acute cholestatic injury are going to be drug-induced, bile duct obstruction, viral hepatitis. Afterwards, consider TPN use, sepsis, alcohol, infiltrative liver disease, postoperative jaundice, and then cholestasis of pregnancy. When we break it down into extrahepatic and intrahepatic, by far the most common thing we see, especially in the hospital, is going to be bile duct stones, choledochal lithiasis, and then think about again the structures in that area. So pancreatitis, biliary strictures, pancreaticobiliary cancer, postoperative bile duct injury, and then when we're talking about acute intrahepatic cholestasis, we're talking about drug-induced viral hepatitis. Also consider alcohol. Infiltrative liver disease can be from malignant reasons like lymphoma or non-malignant like sarcoidosis, and then the right patient, think about cholestasis of pregnancy. Basically, this just shows you it's kind of zoomed in on the the small cells and the ductules there. So if you have injury here and you have cholestasis, intrahepatic cholestasis, the flow through the extrahepatic system is still preserved. So this situation is where we sort of do this progressive diagnostic testing. We said earlier, really for all patients, we're going to start with the ultrasound, but when we're looking for biliary dilatation obstruction, this is when we start to consider, CT, MRI, and then EUS and ERCP. So again, start with ultrasound, non-invasive, cheap, look for biliary dilatation, and then if warranted, then you can move on to either MRI, CT. MRCP does not require IV contrast, and if you have someone that's presenting, especially someone you're worried about cholangitis, if they don't have these symptoms, you can get an MRCP, but if it's clear that they have cholangitis, there's biliary dilatation on the ultrasound, they probably should go just straight for EUS, ERCP. There is risk associated with ERCP. In general, pancreatitis around 5%, perforation around less than 1%, and post-sphincterotomy bleeding around in less than 1%. In cases with intrahepatic cholestasis, liver biopsy can be helpful. In general, this is also somewhat of a low-risk procedure. Bleeding's quite low, death is low. You can have bile leak with pain. You can have perforation of organs like gallbladder, bowel, lung. But again, it may be necessary to help make a diagnosis. So next case is a 60-year-old male. He's got a history of prostatitis. He's treated with Augmentin for 14 days. On day 12 of treatment, he's tired, he's fatigued, and he's actually jaundiced now. So these are his labs on day 12. So you get the labs, his alkaline phosphatase is elevated, his ALT, AST are elevated. It's sort of a mixed pattern, but his bilirubin, is 4.5. So this is concerning. His viral hepatitis markers are negative, autoimmune markers are negative, ultrasound basically normal, no dilated ducts here. So based on the history, you're suspicious for drug-induced liver injury. So it stopped at day 12. You can see over the time period, he had progressive increase in alkaline phosphatase and bilirubin, again, a more predominantly cholestatic pattern. On liver biopsy, you see in the lobules there inflammatory cells, which can be nonspecific, and then within the hepatocytes, staining for bile, which is indicative of acute cholestasis. So this patient, again, over 42 days, basically symptoms and jaundice peaked. He did experience continued fatigue, had some mild pruritus, but overall progressive resolution really without any specific treatment, just recognizing the history there with the new drug and ruling out other concerning things. So bilirubin normalized by day 65. So drug-induced cholestasis can have normal alkaline phosphatase at onset. It can progress even after you discontinue the drug, and it can be prolonged, so 3 months may not be atypical, and resolution is typical with just cessation of the drug. Liver biopsy can help confirm and rule out other etiologies, but it ultimately may not change management. Now, case 5, so we have a 40-year-old female, obese, history of diabetes. She has 1-day history of right upper quadrant pain and fever. You examine her, she's very tender in the right upper quadrant. Her ALT is 600, AST is 400, alkaline phosphatase 170, direct bilirubin is 5, and she has leukocytosis, white cell count's 26, and you get an ultrasound. So the ultrasound shows dilated ducts, gallstones. Obviously, you're very concerned. This is basically Charcot's triad. She's got signs of cholangitis. So she actually, because of that, really should just go straight for ERCP. If EUS is available, can have a US ERCP as well. But there's a cholangiogram there. You can see the filling defect, the stone there, and then endoscopic view, you can see the removal of the stones along with sludge and pus. So this is cholelithiasis with cholangitis, progressive improvement in pain and labs following ERCP, and she's referred for a cholecystectomy as inpatient and does well. So important points for this, acute bile duct obstruction presents early on, and sometimes it's only first an increase in the aminotransferases. Acute cholangitis with evidence of obstruction or stone is really an indication for urgent ERCP, and removal of the obstruction often leads to rapid clinical and biochemical improvement. So in summary, when we're assessing liver enzyme injury, normal is somewhat arbitrary, particularly with ALT, AST. You can have patients with normal liver enzymes, and they still have an underlying liver injury. This is maybe more specific to looking at chronic patients, but there's plenty of patients that have normal liver enzymes that have a chronic liver disease. Alternatively, they may have some mild elevation that you follow over time, but their probability of more advanced liver disease is actually fairly low. So you really have to just look at them as individuals, look at the risk factors, the clinical scenario, specifically look for alarm features. So if you have someone initially, they have more than mild elevation, just first of all look for encephalopathy, coagulopathy. If those are present, this requires urgent referral and hospitalization. But if you have somewhat mild elevations, mild to moderate, and they don't have the alarm features, this is when you can do all your tests, avoid alcohol, avoid hepatotoxic medicines, and then go through your progression of tests. For acute cholestasis, again, it's cholestasis with poor bile flow from intrahepatic and extrahepatic causes. Ultrasound is the best initial test to differentiate between intra and extrahepatic cholestasis. And extrahepatic cholestasis usually involves correction of obstructive process. And if cholangitis is present, again, on a more urgent basis. Intrahepatic cholestasis is usually diagnosed after the exclusion of the extrahepatic causes, and this is where sometimes liver biopsy is necessary. So in this flow diagram, basically you're looking to see is there biliary dilatation, yes or no? Do they have fever chills? Are you concerned about cholangitis? If so, yes, they need to be hospitalized. If they don't appear to have urgent need for hospitalization, they still need an urgent referral for a GI specialist. If you find that there's no bile duct dilatation, you're suspecting intrahepatic cholestasis, do your test to confirm that the alpha phosphatase is from hepatic origin. Again, discontinue any meds that you might think are contributing, and then follow your progression of test. Okay, thank you. Any questions?
Thank you, Dr. Rachel. Excellent talk. Thank you for being here. You're on call, right, today?
Yes.
Okay. Okay. So, great take-home points like when AST and ALT transaminases are more than 1,000, think about like drug-induced liver injury, ischemia. Don't think about like PBC, PSC, because most of the time AST, ALT in thousands will be like drug-induced liver injury or ischemia. And when you have a chronic elevations of LFT, think about other etiologies. Do your first blood workup, like chronic liver disease workup, to rule out all the serological markers and stuff. If that doesn't lead you to anywhere, you can do liver biopsy, which can be done like CT guided, and also like at Borland Groover we do endoscopic ultrasound guided liver biopsy. Advantage of EUS guided liver biopsy is you can do right and left lobe of the liver same time. Also, you can rule out other etiologies like pancreatobiliary etiologies, and less risk of abdominal pain after liver biopsy. So something to think about. Thank you. Yeah, okay. So we'll move to our next presentation. Our next speaker is Dr. Nicole Liu. Dr. Liu is a transplant hepatologist who recently joined Mayo Clinic from Texas Liver Institute UT Health Science Center in San Antonio, where she was PI on several NASH trials. So she's here to talk to us about NASH today.
Good morning, everyone. It works. This is so cool. Okay. I'm happy to see you all. 7 a.m. and after a long week of battling your EMR, you're here to talk about my favorite topic, the liver. So in the next 25 minutes, we're going to talk about the number one consult we see, fatty liver, and I will disclose some trade secrets to you and hopefully help us take care of liver disease, because this is really important. So, all right, let's get started. The forward button. Okay. The objectives of today are to understand NAFLD and what does it mean? Is it confusing? They say fatty liver, NASH, is it interchangeable? Let's talk about that. Let's talk about what we see in clinic, the review, the presentation, and diagnosis. And then let's talk about practical management, because it is hard. I mean, it's hard. I don't know how you guys do what you do when the patient comes in with a problem list of 20, and now we want to tack on for you to take care of fatty liver. It's insurmountable. So let's talk about practical things. All right. NAFLD, non-alcoholic fatty liver disease, is an umbrella term, okay? It encompasses just fat in the liver, which I call cosmetic fat, but they're not going to call that in the literature. It's isolated steatosis. This is fat in the liver. It's not causing damage, no inflammation, no fibrosis. Then you have the spectrum on the other side, which is where the fat is causing inflammation. It's causing damage. The liver's angry. It's getting scarred. This can lead to cirrhosis, and in those individuals, unfortunately, can also lead to liver cancer. In order to diagnose NAFLD or NASH, it's challenging, but first you have to make sure there's nothing else that's causing fat in the liver. Okay, so alcohol use, like Dr. Rachel said, they're not going to disclose to us. It's so hard to get people to tell you that they're drinking, especially if they're drinking amounts that they don't think they should be drinking. Every guideline is a little different. Even in Asia, they have lower amounts. This is like, I just kind of said, maybe 1 drink a day for women, 2 for men. This is a little bit more generous. Hepatitis C can cause fat in the liver, especially genotype 3, Wilson's disease, medications and toxins I have listed here, TPN. So you have to get a really good history. In the world, 25% of the world has fat in their liver. And in the United States, we're overachievers. 30% of us have fat in our liver. And when I was in San Antonio, Texas, 40% had fat in the liver. I think we won. Like, we don't want to win, but we won. And we see a lot of the downstream effects. Liver transplant is needed later. liver kidney transplants. These individuals are sick and they're not perfect candidates to go through transplant because they have diabetes, high blood pressure, high cholesterol, maybe MI, and they're big. And now you want to do a big surgery on them to give them 2 organs. It's not perfect. So this is why we want you to help us intervene ahead of time so we don't have to take them to transplant. So let's take my San Antonio example, because I think the math is a little easier. If I go around San Antonio with a portable ultrasound machine, 4 out of 10 people I ultrasound, 4 of them will have fat in their liver, okay? So let's say there's 4 people. 3 of them, which is 75%, will generally have this cosmetic fat, okay? Traditionally, we were told that forget about it. It's not going to change it's not going to do anything. It's just cosmetic fat. It's not going to really lead to problems later down the line. I'll come back to this. That's the traditional thinking that I was taught when I was a fellow. But there's that 1% out of 4 that has fat in their liver that unfortunately that fat is causing havoc in their liver and their liver tests are abnormal, or they may not be. It could be only histologic level, and their liver is getting more damaged and inflamed. And the damage, the best way I can explain it is that there's something constantly irritating the meat of the liver, the parenchyma. So the best way I can explain this to patients is, let's pretend I have a cut on my arm, and I constantly irritate that cut and continue to irritate it decades. That cut is not going to heal well. It's going to get fibrosed, damaged, inflamed. And that's like the liver. There's something constantly irritating the liver meat, and it's getting more and more damaged over time. Had I just removed the insult to begin with, that liver would have healed. So our goal here is to remove the insult, the fat in the liver, and the risk factors to control them so that way their liver doesn't get damaged. Anyway, so they have NASH, and out of that population that develop NASH, 15 to 25% develop cirrhosis. And it's not overnight. I have patients like, oh my God, I have abnormal liver tests and I might have cirrhosis already. They jump to conclusions, I need a transplant. It's not overnight, okay? Generally, at least 15 years. But, in the literature, they say to progress, there's 4 stages of liver damage. There's normal to stage 4, which is cirrhosis. Literature generally says it takes about minimum 7 years between stages to develop disease. So it's 28 years. But we've seen it faster. So, it's literature, but we've seen it faster. Out of those that develop cirrhosis, 3 to 5% of those, they have a 3 to 5% chance per year of developing liver cancer. So if you have those in your clinic that have cirrhosis that are not being seen by gastroenterology or hepatology, because we're really anal retentive about getting those every 6 months imaging for cancer, make sure please you're doing that. So going back to the traditional thinking where they said that isolated cosmetic fat was nothing to worry about, this blew my mind. Like around 2 years ago, they're like, hey guys, maybe 22% of them cross that border to the other side and actually can get damage to their liver, but we don't know who those people are. Well, that's not helpful. Now I have this whole group of people that we told them that they were fine, and you're telling me up to a fifth of them or more could eventually develop damage in their liver. So this is really important for us. We often send these patients back to primary care. We ask the primary care doctors to screen their liver tests, check on them twice a year, once a year, and that will be really important for you to help us manage these individuals to make sure they're not developing damage and eventually cirrhosis and not us not knowing about it. Okay. Risk factors for NASH. These are the top things you probably see in your clinic, at least in Texas we saw. Metabolic syndrome, obesity, type 2 diabetes, hyperlipidemia, hypertension. Is this like your whole clinic? There's emerging associations that are on the other side. I'm not going to read them out, but polycystic ovarian syndrome is a big one too. I just thought this was an interesting exercise. I was wondering about the obesity rates in our country. In 1990, 14.9% of our country was considered obese. 2019, do you guys have a guess? Sorry? 33. Yeah, 40 something. Yeah. And then, this is a New England Journal paper, just pulled up. It's all pink. But they didn't give a big number, but you'll see 50 to 60% is what our country is seeing by 2030. So this problem is not going to get better, it's just going to get worse. It's almost like that movie WALL-E, like where everybody's in that wheelchair and they're like surfing. It's not getting better. It's not getting better. All right, what are we going to see in our clinics? NAFLD affects, usually the reason I saw so many NASH and NAFLD patients in San Antonio is because it affects mostly Hispanics. but it also affects Asians, Caucasians, and less likely African Americans. They think in Hispanics because they have the PLA3 polymorphism, they're more, it's like some genetic component that they're more likely to have fat in their liver and you develop NASH. So it's not fair to them. The Hispanics, just make sure, especially in your Hispanic population, you keep an eye out, okay? Usually they're asymptomatic. Their fatty liver doesn't cause them problems physically. Sometimes, you know, they might have a little bit of right upper quadrant pain, but usually asymptomatic. And I really wanted to point out this type 2 diabetes because in your clinic, you have a lot of diabetics. And in your diabetic population, 60% of them will have fat in their liver. That's even worse than my San Antonio population. We're looking at now just diabetics. So please make sure in your diabetics, you're keeping an eye on them, especially the long-term diabetics, and we'll talk about this later. All right, so Dr. Racha had mentioned ultrasound is a good tool. Ultrasound is great at looking at fat in the liver, but it can only detect if it's 30% or more. But then you get these reads from your, it depends on where you go to for your radiology center. They might just say, oh, it's hepatic steatosis, period. That's it. But others might say, the liver is echogenic, rule out hepatic steatosis versus fibrosis. I think that's the better answer because you can't tell on this ultrasound if it's fat or if it's also damaged, or it could be both. But it's a really good starting point, okay? CAT scan, you would think, like, oh, it must be a better scan, it's cross-sectional. Actually, it's not better than ultrasound. The only reason it would be better is if you really have a large person and maybe, and then, you know, and they have 30% more fat, okay? MRI is the best modality to get a look at the liver. It can detect fat as little as 5%. But, I mean, to order it off the bat, and even to order it later, most insurances, peer-to-peers, etc., it's just, it's hard. It's really hard. But this is our best study. Okay. Dr. Racho had mentioned that he had those liver tests. He had those bars about what to look for. This is hepatocellular, usually, for NAFLD, usually in the 40 to 200 range, which is usually 3 times to 4 times the upper limit normal on your ranges. Not what he was saying for normal. For women, it was like 19 and men 30, but no, we're talking about the range on your normal bar. Alk-Phos can even be elevated in up to a third of patients. GGT is often elevated. And really take a look at the other markers, what he was talking about, the functions. Albumin, PTI, they're usually normal unless they have advanced liver damage. And you usually see this too. If you're going to be a go-getter and do all the testing for abnormal liver tests, you may be like, well, why did I do that? You may see a couple, how do I fix this? Can you hear me? I don't know, I think I talk too much. Okay, it's a signal. Okay. All right. You overachieve and then you order all these tests and you're like, oh, I shouldn't have ordered it. I don't know what to do with this. So I just want to let you know, ANA can be positive in fatty liver and also in alcohol use, but in fatty liver, up to 33% of patients can have this false positivity, okay? And also AMA can also be positive. It's probably this epiphenomenon. We don't really know why. Generally, this is confusing. You're like, oh, I just biopsy this patient. They have an autoimmune marker positivity. We often look at immunoglobulins, but that's CO2. We don't have to talk about that. But if there's a competing diagnosis, liver biopsy is usually the way to go to figure out what's what. Then you might see, oh, do they have hemochromatosis? Their ferritin's elevated. Like, why did I order that? It can be elevated in 50 to 60% of patients because when the liver is inflamed, it's an acute phase reactant, the ferritin also goes up. So we don't know. If you want to do, if their iron sat is over 35%, you want to order HFE testing, fine. Again, liver biopsy is another way to solve this issue. So when do we really biopsy? This is the big question. NASH is still, and to this day, 2021, diagnosed by a liver biopsy. There's so many clinical trials for NASH, they want to get rid of the biopsy, but still, they're having a hard time trying to get rid of it. But who do we biopsy? Those who are at increased risk that we talked about, age, they're diabetic, Hispanic, and I'll talk about the other ones later. Or if you have competing diagnoses, you do the whole workup and you're like, well, they could have fatty liver based on their risk factors, but then I just uncovered autoimmune, elevated ferritin, all these things. I can't tell. I can't tell what it is. So the biopsy would be the next step. The thing about biopsy is that biopsy is going to tell us two things. Number one, why are the liver tests elevated? But it doesn't always tell us why. because the liver biopsy is a little sample of the liver, 1/50,000th of the liver, and where we biopsy is random based on the best spot we can get to. And you're assuming that one spot you biopsy is going to represent the entire liver. I always tell patients, like, don't pin your hopes and dreams on the biopsy. We're going to try to figure it out, but, I'm going to give myself a back door just in case we don't, because I see this often. But anyway, it will tell us, number one, why the liver tests are abnormal, and number two, how much damage is in the liver, okay? When you look at a biopsy for fatty liver, you have to always make sure you get a very clear history and really ask about alcohol use. Because if you have someone who's drinking alcohol, that causes fat in the liver, and you can have someone that's not drinking alcohol, who has all those metabolic risk factors, you send those two biopsies of those different people to the pathologist, they cannot tell on the histology who's who. Alcohol and NASH look essentially identical. Okay, so you have to really make sure you get a good history. Okay. What do we see? Steatosis, and here are the levels of steatosis: mild, moderate, and severe. Here you see the fat droplets, and next to it is normal. You'll see swelling of the liver cells. They're getting stressed and they're dying. Okay. And based on the findings, the pathologist will give us a score. Oh, there's this much steatosis, there's inflammation in this pattern, there's this many cells dying, and they'll give us a scoring. You'll see a scoring system at the bottom of your report, and it's the NAFLD activity score. How to interpret is generally, preclinical trials we usually say 4 and above, fine. If it's 4 and above, we can call it NASH, but if it's under 4, then we would say, like, probably not NASH. But like I said, remember, it's like a sampling, so, but in that, it's really hard. I think the biggest challenge is what I've learned in clinical trials is you have one pathologist read one biopsy, and you have another one read the same one, and they may call the NAS score differently. So use your big clinical judgment too, but this is how we generally diagnose it histologically. This is about the fibrosis staging. It's important to know because this drives how you manage them. If they're low fibrosis scoring, like 1, 2, then you can be more relaxed about it. But if they're 3, 4, this is when you want to be more pushy and refer to us. Refer to us anytime, but this refer to us definitely when they're 3, 4. Okay. You might see this too. You get a biopsy back and it's a cirrhosis and there's no fat in there. And this patient just completely meets your criteria for fatty liver. What happens over time, we don't know when this happens, the fat and all the evidence of why that liver got damaged dissolves out, and all you're left with is just scar tissue. And these individuals, unfortunately, often get grouped into this cryptogenic cirrhosis when you know deep down that they're fatty liver. So we call these groups burned out NASH. Okay. All right. How to practically manage these patients. And this is a little campy, I'm sorry. I was really excited about the GIF. It's really important. You guys are frontline. You guys have to be on the lookout for these patients. If you don't find them and identify these patients, we don't get them. Those patients also don't have the opportunity for us, you to intervene or for us to intervene before they get cirrhotic. Okay, so why should we care? NAFLD, 2 times increased risk of heart risk, and they're more likely to die actually of heart disease than their liver disease with these patients, okay? Increased mortality is related to their fibrosis staging, okay? And so if they're stage 3, 4, and they develop cirrhosis and then cancer, they're at higher risk of dying. And this is a paper by my friend Amaya Rochester. She compared just looking at patients who had obesity alone versus obesity and NAFLD. And those patients with NAFLD, for some reason, had a much higher risk of extrahepatic cancers. So if I were queen of the world, and I was in the clinic kind of coaching you like who to screen, there's no screening guidelines. All the societies kind of disagree, and it's not cost efficient to just screen everyone. So if I were queen of the world, this is what I'd say. If you have someone who has abnormal liver tests or steatosis in the setting of prediabetes or type 2 diabetes, please, yeah, that's like slam dunk, go for it. Otherwise, your type 2 diabetes, the long-term ones, the ones who are age over 50, metabolic syndrome, obesity, you don't have to have all of these. Go with your gut. Screen. If you have someone with diabetes and you're like, oh, I don't know why their platelets are low, like this is, I might see in the hematology, I see a lot of that pathway, that could be their liver. When you have cirrhosis, okay, with changes of blood flow, eventually the spleen gets enlarged. You might see that. You're like, why is your spleen enlarged? and the platelets go low, that is a sign that they could have advanced liver disease. Okay, so that, if I were the queen of the world, this is what I'd say. 6 days ago, the American Gastroenterological Association had this call to action NASH tactic about how to screen. I don't know if I'm still thinking about it, but I just wanted to throw it out there. They suggested, frontline, use your blood work, if you can see right here, look at non-invasive markers for fibrosis first by your blood work. And this is, I don't know, has anybody used the FIB4 score or the NAFLD fibrosis score?
Is that the FibroSure test?
Yeah.
Well, the FibroSure test is the one you send to like LabCorp, and then they give you, I think that might be faster for you guys, because I'm like, you guys have only like 15 minutes to see a patient. You don't have time to do all this. So they're suggesting you do this first, but I agree with you. So skip this. So let's skip this. And they might not like me, but whatever. What you're talking about, the NASH FibroSure test, that's easy. You just order it, and then if it says it might give you a risk, like what degree of fibrosis, you can go with that. That's their second tier triage right here. And if it's lower risk, they're suggesting repeat in 2 or 3 years and following up. But if it's high risk, stage 3, stage 4, refer to us. But that might be the faster way to go. But I would still, if it were me, like I said, if I were queen of the world, I'd still go by this. Those tests are not always accurate. So, and how many of you have fiber scans in your office? No. Okay. All right. Just wondering. They also suggested that as a triage tool. Okay. All right. Let's just talk about treatments. It's not easy. When I was in San Antonio, I don't know if it was cultural, I would say someone was, you're a little overweight, obese, you need to lose weight. They did that. Like, I had a patient lose 35 pounds, looked perfect. Her liver test got better, almost normal. And her family told her she looked sick and too frail. She gained it all back, okay? So I know it's also cultural. This is not easy, okay? But the cornerstone of treatment is weight loss, okay? 3% of weight loss at least can dissolve fat from the liver. 10% can dissolve fat and reverse damage to the liver, the fibrosis. And I just have to put this out there, those stages of 1, 2, 3, 4, 0 being normal, so I'm just calling 1, 2, 3, 4, 5 fibrosis staging, 4 being cirrhosis. The fibrosis in the liver is reversible generally up until stage 3, okay? I hear this all the time, doesn't the liver regenerate? Why can't I just it regrow back? But the regenerative capacity that reserved the liver is really just maintained until stage 3, except for extenuating circumstances. So, goal is 0.5 pound to 1 pound weight loss per week. If you go more, your body thinks it's in starvation mode and might hyperstore fat in the liver, and that could actually make it worse. Nutritionists, commercial products, Jenny Craig, etc. Bariatric surgery. I myself am not very good about this. I don't know if Dr. Rachel is better about it, about referral. I feel like I've already insulted the patient, like, you're overweight, obese. Let's talk about bariatric surgery. And I feel like I insult them. So I need to learn my way of how to transition that. But unless the patient brings it up, I'm not very good about this. But it is the most effective therapy. Okay. The task force also has this diagram of how they would suggest treatments. But I'm just going to, I don't know. I put it up here just so you know that there's consensus and this is what they recommend. But, this is not practical always. So let's talk about what we can do. Vitamin E, generally given and proven to be possibly effective to dissolve fat in the liver, and those who have biopsy-proven NASH who are non-diabetic. But they're like, what if I give it to someone who's diabetic? Newer data is showing that maybe it can be helpful, okay? There's also conflicting data. There's like all-cause mortality may be increased with vitamin E. I don't think you can win in medicine. We're still a black box. 1 year it's good, the next year it's bad. I would say use your judgment, but at least under the auspices of our liver association, non-diabetics, biopsy-proven NASH. Or even if they are not biopsy-proven, they're non-diabetics, what do you have to lose? That's my practical side. Pioglitazone. This is endorsed by our society. I tried to give this. Patients end up, the fat gets redistributed and they gain weight elsewhere. They hate me, but this does reverse steatohepatitis in the liver for patients. How many of you guys use pioglitazone? A lot? No? Yes? Okay. A few hands. What about this? GLP-1 receptor agonist. You guys use this a lot? Is this your go-to? Yeah, I would say use this. If you have someone who has fatty liver, if you can, use this. Semaglutide, Trulicity has the best data. And I just threw up some information here. I know we're short on time. Saxenda also has data supporting it too. The SGL2 inhibitors also has emerging data, but not as strong as your GLP-1s. So, if you have it, you might be like, oh, they kind of fit, they're diabetic, I have an excuse. And if you can get it approved, I don't know how expensive are these? Are they expensive? Oh, just kidding. How expensive is Trulicity? Is it hard to get?
Like $600 for 30 days.
$600 for 30 days, okay. Okay, I didn't know that because we don't know the practical side because we don't do this, okay.
Ozempic has a card they can get.
They all have pretty good coupons.
Okay. Okay. Well, these would be practical tools in your tool belt. And then I just read, might have been a couple months ago, that now the semaglutide is being approved for weight loss.
Yes.
Yes, so that might be another strategy too. So,
Wegovy.
sorry?
It's called Wegovy, I think.
Okay. Yeah, I have a lot to learn from you guys. Yeah. So, thank you. I get this question a lot. I have patients with fatty liver, they're primary care doctors. Understandably, take them off their statin because it can cause liver test abnormalities. Please put them back on it. It's okay. The liver test can be abnormal the first 6 weeks to 6 months, but put them back on it. It helps dissolve the fat from the liver, helps them improve their cardiovascular risk. This is the trade secret I wanted to tell you about. I touch this site multiple times a day, and it's free. It's called livertalks.gov. It is a National Institutes of Health database of medications that can cause liver injury. It is awesome, okay? And I even give it to patients because if I don't have time to look up they have 50 million questions of all the, I'm look them up individually yourself, and there's even a category. So when you type it in, you'll see the background information of the medication, what it does, and then there's a category that's just called hepatotoxicity, and then they even give you a probability score, like a score, letter score of if it's a common cause of liver injury. And so a lot of those obscure medications I've never heard before, like there's these MS medications, all these medications are new and coming out. Often it's in here, and I'm surprised. And that could help guide you if you're worried about their liver. So, just in summary, be on the lookout for an NAFLD-NASH, please, in your clinics, your front line. Weight loss is the mainstay of therapy. It can lead to improvement in steatosis and fibrosis. Use these diabetic meds to your advantage. Statins are safe, and use livertalks.gov. These are our trade secrets, and now they're not secrets anymore. If you have any questions, please don't hesitate to email me. Here's my email address, and I really appreciate your time. Thank you, guys. How do you do that?
There are so many other medications are on the horizon for the NASH diagnosis itself. At Borland Groover, we have a research arm, ENCORE research group. We have, I guess, 2 trials for NASH going on right now, so feel free to refer us a patient in our clinical trials. If everything is covered, all the visits and everything, and we can give them more information if they're interested in the NASH trial. Okay, so we'll move on to our next presentation. Our next speaker is Dr. Scott Ackerman from Ackerman Cancer Center. He's about Ackerman Cancer Center. He's a board certified radiation oncologist and medical director of Ackerman Cancer Center. Has locations in Jacksonville and Nassau County. And I can safely say that this is the only one treatment center, proton treatment center in the country, which is in a private setting, right?
Thank you. Yes.
Okay, thanks, Doc.
Thank you, Kanish. Excellent, sir. Thank you. Thank you. This is the
clicker.
clicker and the pointer, I guess, right? Not that I'm going to point anyway. I don't think I'm pointing anyway.
Okay.
It's hard to get the laser on the screen. Anyway, good morning, everyone. My name is Scott Ackerman, and I'm a radiation oncologist. And I guess you don't get radiation oncologists that often here in the room. I think you have a medical oncologist later today, Dr. Zayden, who I collaborate with a lot. And I'm very glad and honored to be asked to speak today. I'm going to talk about esophageal cancer, and specifically I'm going to talk about proton beam radiation as a way to minimize side effects of treatment and improve outcomes in the treatment of esophageal cancer. And so let's proceed. There we go. Oops, too much. So here's my kind of outline of my talk. I'm going to go through some basic science about esophageal cancer, talk about staging a little bit and the different types of treatment. And then we're going to spend the second half of the talk specifically talking about proton beam radiation and why proton beam radiation is advantageous over conventional radiation in the treatment for esophageal cancer when radiation is being used. I'm not necessarily I won't be advocating proton radiation over surgery or over chemo. I'm going to be talking about how proton beam therapy's outcomes are better than with conventional radiotherapy outcome in esophageal cancer. So esophageal cancer only represents about 1% of new cancer cases annually, but for the Borland Groover group here, it has a lot higher incidence than that. There's about 20,000 new esophageal cancers in the United States. It's predominantly a disease of men to women. You see it's about 4 times the number of men to women, and it's a very deadly cancer. 15,000 deaths this year of the nearly 20,000 cases. So that's 3/4 of the patients with esophageal cancer will die of their disease. The rates have been stable, although slightly down over the past decade for whatever reasons. Survival has been abysmal back in the 60s and 70s, but we're seeing about a 20% 5-year survival now, and that's because of advances in treatment, understanding esophageal cancer better, diagnosing it maybe a little earlier. I don't think our early diagnoses, I don't think we've made any great leaps in early diagnosis of esophageal cancer. And there's a little infographic on your right. You can see that the overall survival is about just under 20%. 70% of patients who present with esophageal cancer already have it's already in their lymph nodes or have distant metastatic disease. So that means only 30% have it without it being in the lymph nodes. And the survival, you can see if it's localized, stage 1 or stage 2 disease, where it's only involving the esophagus before involving lymph nodes, there's good survival there. Just over 40% 5-year survival. Once it's involving lymph nodes or adjacent structures outside the esophagus, it goes down to 23%. And patients with distant metastatic disease have only a 5% 5-year survival. There's a picture here. This is what you see. This is what Dr. Changela sees when he takes his scope and looks down the patient's throat. There's a typical esophageal cancer. The pathology of esophageal cancer is 95% squamous cell or adenocarcinoma. This make up nearly all the esophageal cancers. There's a couple other cancers of the esophagus that are very rare. There's minor salivary gland tumors of the esophagus, like adenoid cystic carcinoma we see now and then. We even see some sarcomas that begin in the muscular wall of the esophagus, and they're very unusual, but we see them sometimes, and they're rather difficult to treat. So the way to remember squamous cell and adenocarcinoma: squamous cell is usually the upper esophagus, adenocarcinoma is usually the lower esophagus. Adenocarcinoma is a disease of white men primarily, and the men outnumber women in adenocarcinoma, the distal esophagus, by 6 to 8 to 1. Adenocarcinoma is usually associated with Barrett's or esophageal reflux disease. Those patients who have Barrett's or esophageal reflux need to be followed, should have upper endoscopies more regularly. I'll leave it to these guys to tell you how often, but I certainly would think every 5 to 10 years to have an upper EGD to monitor that. And certainly treatments for esophageal reflux will minimize the risk of progression to cancer. The incidence of esophageal adenocarcinoma is 4.2 per 100,000 per year in Caucasian men, and this is double that of Hispanics, and fourfold higher than blacks or Asians. So it really is a disease of Caucasian men. Now, squamous cell carcinoma is opposite. So squamous cell carcinoma is usually the upper esophagus, and It's similar to cancers of the oropharynx and larynx. It's really an extension of that, and it has risk factors that are similar to head and neck cancers, risk factors, smoking and drinking and those sort of things. I think we're starting to see some, as we're seeing a lot of HPV-related oropharyngeal cancers, we are seeing HPV-related or HPV-mediated cancers of the upper esophagus as well. These are more common in African Americans. Incidence rate is double, 8.8%. I'm sorry, 8.8 per 100,000. That's double the rate of adenocarcinoma in the distal esophagus in Caucasians. So this is a disease primarily of African Americans and mainly men, and it's also more prevalent in Asians as well. So, what are the signs and symptoms of esophageal cancer? So you, as a primary care physician, the things to think about to make a referral for an EGD or for evaluation by gastroenterology is dysphagia. That's with obstruction, chest pain, tumor growing through the esophageal wall into the chest, a chronic cough. That when esophageal cancers get larger, they impinge upon the trachea. Maybe not direct extension, but just this mass effect in the chest will push some pressure on the trachea, and it'll cause irritation. Patients won't be able to get the phlegm up as easily, and they'll have a chronic cough. If there's bleeding, and there's frequently bleeding associated with esophageal cancers, patients can present with anemia. They frequently present with vomiting blood if it's a lot of bleeding, and they can also present with melena. We think of melena typically an upper GI tract bleed. Upper GI tract includes the esophagus, so it's not necessarily, we think about melena a lot with gastric bleeding and duodenal ulcer disease and that sort of thing, but also esophageal cancer can present with melena. Hoarseness, typically associated with upper esophageal lesions, but it can be mid-esophageal lesions if there's adenopathy associated with them and impingement upon the recurrent laryngeal nerve. Weight loss because of just mechanical inability to eat, and sometimes bone pain if there's a metastasis. So here's what these gastroenterologists see when they take a look down. They use this fancy ultrasound. So part of our staging workup is to do an endoscopic ultrasound. So I showed you before what the cancer looks like, and we always want, as oncologists, we'd like to have an endoscopic ultrasound. That really helps us with knowing the extent of disease, and we really need that for management. This endoscopic ultrasound tells us not only the depth of the tumor, but also tells us if there's any lymph nodes in the mediastinum that are involved as well. And this is what the endoscopist sees. The probe is put into the esophagus, and you can see in the upper there a small T1 lesion just grows into the mucosa. A larger T2 lesion grows into the muscularis, and then a T3 lesion grows into the adventitia, and you can see it with a T4 lesion, and the endoscopist can see that it grows into the adjacent organs. And down below there is kind of a blown up picture there, and you can see all the different layers of the esophageal wall. And this is a T3 lesion growing into the adventitia. You can see the aorta there right next to the esophagus. So in our diagnostic workup, once we get a biopsy, we also want to get, as I said, an endoscopic ultrasound, very, very important, a CAT scan. Sometimes we get an MRI. I'm not that keen on getting MRIs in esophageal cancer, but it can be helpful. And MRIs can also help us in lieu of an endoscopic ultrasound. So EUS, I think, is the gold standard. But if you can't get an EUS, MRI is second best. And MRI will show us the different layers of the esophagus that are involved with tumor. PET scan, I always get a PET scan on esophageal cancer patients. That helps us as a rate for radiation therapy planning. We like it to see the full extent of disease. It's hard to see submucosal disease, full extent up and down, but a PET scan helps us with that a lot. And biopsy, I know that goes kind of without saying, but let me talk about a biopsy a little bit and what the importance of the biopsy is and the things we're looking for. So it's not just squamous versus adenocarcinoma, or one of the rare ones, but we also look at other things when we do a biopsy. There's all sorts of tumor markers now, and there's all sorts of genetic analyses that we do on tumor cells. And so this not necessarily, at least today in 2021, helps us with initial treatment, but subsequent treatment for relapse, treatment for metastasis. So HER2 is one thing. You may have heard about HER2. We talk about it a lot with breast cancer. Breast cancer, whether it's HER2 positive or negative, you hear about that in a drug called Herceptin. It's also with esophageal cancer. And in patients that have relapsed disease, we could use Herceptin in those patients that are HER2 positive. So knowing that on the front end, when the initial biopsy is made, we have that in our back pocket for future strategies. And then PD-L1. You may not have heard of PD-L1, but you watch the commercials on TV all the time for Keytruda. That's a very expensive immunotherapy and a very, very effective immunotherapy, mostly associated with lung cancer. But PD-L1 is so PD-L1 is immunotherapy. So if a patient has a PD-L1 positive tumor, that means these drugs like Pembro, I can't even pronounce the whole thing, it's just Pembro is what we say, but it's Keytruda, they will jack up the body's immune system to fight the cancer. And we use it all the time in lung cancer. I cannot tell you how many patients I have with metastatic lung cancer. There are 5-6 year plus survivors because of this miracle drug of Keytruda. So the medical oncologists come in and tell them I say good things about them. I do like them. And so we see it also. I have patients with bad skin cancers. These are squamous cell cancers that are spread all over the body, and they're doing phenomenally well with Keytruda. With esophageal cancers, some of them are also PD-L1 positive. Squamous cells mainly, but some of the adenoids can be also. So it's important to send for PD-L1 early on, so we have that in our back pocket. The staging, as I said before, I kind of try to show you in the EUS, but here's a kind of a graphic of it. T1 lesions are ones that are involving the lamina propria, or basically the submucosa. T2 lesions involve the muscularis, that's the muscle around the esophagus. So if it's before the muscle, it's a T1. If it's in the muscle, it's a T2. If it's beyond the muscle, into the adventitia, it's a T3. Real easy to remember. Esophagus is lined with the mucosa, has a muscle, has a wrapping on the outside, the adventitia. So the mucosa is T1, the muscle is T2, the adventitia is T3. If it goes into another organ, then it becomes a T4 lesion. And there's subtypes of the T1 through T4s. I'm not going to bore you with that right now. And then we look at the nodal metastasis. We used to just do node positive or node negative, but now we've found that there is some prognostic value in knowing how many nodes are involved. This is the latest update to the staging from a few years ago. So when you have only a few nodes positive, the patients have a better prognosis than multiple nodes. And then you see distant metastatic disease, that's the liver involvement. So the treatment of esophageal cancer, if it's caught very, very early, there's approaches that the endoscopist can make called endoscopic mucosal resections. But these are just for the smallest tumors, these so-called T1a lesions. So let me go back for a second. These are ones that are just going through the basement membrane into the lamina, maybe into the lamina propria, not much deeper than that. And these are wonderful things that can be done, and if they're found early, it's really a great way to resect the tumor and to control the tumor without a lot of morbidity. And we certainly want to try to minimize morbidity, and that's why I'm going to talk about Photon Beam in a second, because that's what that's all about. Esophagectomy is used in early stage disease as well, in the T1 lesions, ones that are not amenable to a submucosal resection, but still only those patients that are node negative and have small tumors that aren't very invasive. But once you get into a T2 lesion involving the muscularis or beyond, or a node positive, all those patients receive chemotherapy and radiation therapy, and hopefully surgery, depending on the response. So radiation therapy is used in probably 3/4 of the esophageal cancer patients. So most patients with esophageal cancer will need radiation therapy as part of the treatment. The best treatment for these advanced tumors is what we call trimodality therapy, chemoradiation followed by surgery. These are the patients who have the best long-term survival that have advanced disease. And so I'm just, without getting too granular with that, the whole point is that radiation is a cornerstone of the treatment for esophageal cancer. And here's kind of quickly going through this. This is the NCCN guidelines. We use, all of us oncologists like to look at what the NCCN says. That's the National Comprehensive Cancer Network. It's really an amalgamation of the top 20 or 25 research institutions in the country, and they have a committee for every kind of cancer, for breast cancer, for gastric cancer, for esophageal cancer, for whatever. And each committee has one member from each institution. Those members could be radiation oncologist, a gastroenterologist, an internist, a medical oncologist, and they come up with consensus statements about screening, diagnosis, screening, treatment, but what I'm showing you here in these slides, I want to pass through very quickly, is that, again, radiation is a big part of almost every patient with esophageal cancer, be it upper or lower esophageal cancers, adeno or squamous cell. So let's get into radiation just for a second. Let's get into radiation more than a second. So esophageal cancer and proton beam radiation, that's really what I want to focus on today and tell you why that's kind of the shiz. So we at our office use both conventional, what's called IMRT radiation, that's photon radiation. That's the typical radiation that 99% of patients around the country that have radiation treatments receive. We also provide proton radiation. So we do both in our office, and we use it appropriately for patients. So not everybody needs protons. We have actually most of our patients receive conventional photon radiation with what's called IMRT, which is intensity modulation of the radiation. Protons use high energy proton beams instead of X-rays to deliver radiation. So I'll get to that in a second. So at our office, we've treated over 2,000 patients since 2015 with proton therapy, and about 100 with esophageal cancer over those 6 years. Our esophageal cancer patients who receive proton therapy have better outcomes than the ones that have received IMRT radiation. They have a lower incidence of acute toxicities, they have less postoperative complications, and shorter hospital stays. They don't have better survival, they don't have better local control, but they have better outcomes in that they have better quality of life, they're in the hospital less, they need feeding tubes less, they have less esophageal leaks, they have less infection rates, those sort of things. It really is the most advanced form of radiation that we have today. So here's what protons are. Protons are big ion, right? You have the atom, it has a proton, a neutron, an electron. So we take a hydrogen atom and we tear off the electron, and we take that hydrogen, the proton that's in the middle, and we excite it. We send it around a cyclotron to impart a lot of energy into it, and we impart a ton of energy into it, 250 million volts of energy into that proton, and then we shoot it at the patient. It goes into the patient, and it goes deep into the tissue, and then when it stops, it releases the radiation. It releases radiation energy. So as it goes in, very little radiation is being deposited. When it stops in depth, the radiation is released like a firecracker, and then nothing goes beyond. With conventional radiation, it's a radiation beam. We take an electron, accelerate it, hit it into a target, and then the X-ray radiation comes off that. Just like you do in your office, maybe if you do a chest X-ray, or if you use fluoro, those are 100,000 volts of energy, and that radiation beam goes all the way through the patient. That's why you can get an X-ray picture. If we take the proton and shoot it at a patient, we can't take an X-ray picture because it goes in and stops right in the tumor. But with a regular X-ray machine or linear accelerators that produce very high energy radiation, they put much higher energy through the patient. That goes all the way through the patient. The protons just go in to the tumor and stop. And the depth that protons go in is determined by how much energy we impart to the proton. And we could dial that up or down. And we dial that up or down because some tumors are deep and some tumors are superficial. Some people are big and some people are small. So in the esophagus, which is what we're talking about, if it's a big patient, we're going to jack up the energy on the protons a little bit more than if it's a smaller patient, where the depth is different. So what you see here in that curves on the left is the purple curve is a photon beam. So we take photons. That's just like the X-ray machine in your office, but our photons, instead of being 100,000 volts that we have in my office, are 10 million volts of photon radiation. And that beam, as it goes into the body, it deposits radiation, fairly high dose, just below the skin, and then as it goes deeper into the body, less and less radiation is deposited, but it goes all the way through the body. And the way we get a high dose of radiation to a structure in the body, say it's a pancreatic mass or esophageal mass, we do many different beams. We do 7, 8, or 9 beams. And when all those beams meet, that net sum of radiation is the radiation dose. And so each beam delivers a low dose relative to the total dose of the tumor. The protons, on the other hand, as you can see in the blue line, they go in, and deposit a very low amount of radiation on the way in. And then when it hits the end, what's called the Bragg peak, it stops, and it releases all the 90% of its radiation energy right there. And because that Bragg peak is very tiny and very narrow, we send in protons of many different energies to spread out that Bragg peak, what we call the SOAP, spread out Bragg peak. And that's what you see there where the tumor is. And I don't know if I can you see my arrow? Or no? No, you can't see. I'll just go over here a second. So here's where the tumor zone is. So what we do is we send protons of different energies in, so we get the toast spread out around the tumor, and then nothing goes behind. And these purple hash here, the purple hash here, that's unnecessary dose that the patient receives if they were to receive photons instead of protons. So that unnecessary dose is spread out to other structures in the body. So there's another picture of the radiation, kind of a graphic going into the tumor. The protons go in, and no dose goes beyond the tumor. Very low dose on the way in, gets the tumor, stops, and releases the radiation. Here's the room. UF has protons as well. We have a more compact unit. They have the cyclotron that jacks up the energy, and the protons is very big. And UF is as big as this room. It was one of the first generation ones. It's huge, and what they do with their machine is they jack up the energy of the protons, and then they send it down a hallway, literally a hallway, and it goes to different treatment rooms where there's gantries that direct the protons. So they can treat one room at a time and direct into the room. We just have one room, and ours is a synchrocyclotron. So we use a superconductor magnet that's chilled to nearly absolute zero. It's 4 degrees Kelvin, which is pretty low. And it's very, very cold in there, and because of that, it's superconducting. We can get the same magnetic flux in that cyclotron and have it small, as opposed to having it in a big room. And with a smaller cyclotron, and ours, as you see in that picture, is probably 6 foot in diameter, we can rotate it around the patient and send the proton beam right out from that. So we only have one treatment room, but the cyclotron's in that room. It's much more efficient, and it'll come back. Okay. It's much more efficient. It just comes right out of the patient. We don't lose protons going down the hall. When you take the protons going down the hall, you're going to lose some energy. You lose some protons. Just like you put electricity in a wire, the longer the wire is, the less you got, less amperage you have at the other end. And so our room is, it's a huge room to me. It's small compared to what they have at UF, but it's still huge. It's a 3-story room. The middle story is where the patient is. The third story and the lower story is where the cyclotron rotates above and below the patient. The patient's on a robotic table there, so we can position them, and we use image guidance within that room to localize the tumor every day and make sure that they're aimed very, very precisely. So here's some examples of non-esophageal cancers. So this is the top is a prostate case. The lower one is a orbital nerve tumor. And just to talk about prostate for a second, on the right there are photons, IMRT radiation. We send in the beam from seven or 8 different angles, and you see the yellow circle there, or the red rather, in the middle is the prostate. That yellow is the volume that we want to radiate, that yellow dose. But you see that most of the pelvis is receiving this blue, this blue. So these colors, the hotter the color, the higher the radiation. But even these cool colors of blue is a low but meaningful dose of radiation that could have long-lasting side effects. On your left is the proton plan, and you can see that we send 2 beams in, one from the right and the left, and a low dose is delivered to the hip still, but that's a lower dose than that we get with the photons, and virtually no radiation to the bladder and the rectum, which are anterior and posterior to the prostate. In the brain, the lower picture is the orbital nerve tumor. We do the same sort of thing there. You can see on the right with the photon IMRT plan, the normal brain tissue receives this low dose of radiation, and that's associated with cognitive decline and long-term cognitive decline. And with the more focused proton beam radiation, the brain receives very, very little. And most of the brain receives nothing, literally nothing. Here's esophageal cancer. So I'm going to go to the next slide in a second. I just want to show you kind of the way we do our planning. On the right is an IMRT photon plan where the beam comes in from many angles. We evaluate it axially, sagittally, and coronally. And again, you can see there that color wash of that light blue, and even the red there is a lot larger than it is with the proton plan, which is on your left. And just to get kind of a close-up of just the axial here, the tumor is right in here's the esophageal tumor. This yellow is the volume we want to radiate, and you can see here with a photon IMRT plan, the liver receives a lot of radiation. A lot of the liver receives a low amount of radiation, but it's a lot of the liver. The heart, which is right here, a lot of the heart receives a low amount of radiation. With the proton plan, the heart is virtually completely spared. The liver, just a little bit of the liver. You'll see kidney dose in a second and other doses, but it's really the cardiac dose and the hepatic dose, which is much, much more spared with proton beam radiation. Here's a kind of a graphic of it. What we do is called a dose volume histogram. The dotted lines are the IMRT radiation. The solid lines are proton. We want these lines to be as far to the left as possible. The more to the left, the lower dose of radiation to these specific organs. So the yellow is skin dose. The orange here is the heart dose. So with IMRT, the heart receives this. The protons to over here. This color here is the liver. You see the liver is much lower radiation here. And then we have the normal stomach and the small bowel in there as well. And here's a study from MD Anderson in Houston where they looked at comparing IMRT with proton beam radiation, and they did this is a summary of 70 some odd patients and the average doses with proton beam radiation compared to IMRT radiation are given there in that table. So you see the spinal cord dose is actually a little bit higher with proton beam radiation in this case. Our tolerance to the spinal cord is 4,500. So we're below it either way, and there's not much difference there. But the real key is that is those other numbers. So the volume of the lung that receives more than 5 gray is only 1/4. It's 10% of the lung with protons versus 42% of the lung with photons. The volume of the lung receives more than 10 gray is 8% with protons versus 29% with IMRT. The 20 gray dose, the 20 gray of radiation causes radiation pneumonitis. And so the volume of the lung that receives more than 20 gray is only 7% with protons, and with IMRT it's 20%. That's a lot of the lung receiving 20 gray. The mean lung dose you can see is less than half with protons. The mean heart dose is only 1/3 with protons. The mean liver dose is 1/10, and the kidney dosage you can see there as well. So when you have liver dose and when you have cardiac dose, you have hepatitis and you have coronary artery disease. Every 100 centigrade that the cardiac dose goes up increases the risk of a MI later in life by 7.5%. So there's a big difference there. The patients will have a higher incidence of a cardiac event later on with IMRT radiation. Here's survival. So this is a randomized study at MD Anderson in Houston looking at protons versus IMRT in patients with esophageal cancer. And here's the local control. On the left is progression-free survival. On the right is overall survival. And those are not statistically different. So this overall, the local control and progression-free survival is no different with protons than it is with photons. So I'm not here to tell you that we have better cure rates. What I am here to tell you is that we have less side effects and less morbidity. So this is I thought this was a really cool table, and let me explain it. The hotter the color, the worse the toxicity. The cooler the color, the less the toxicity. So let me go over here to the left now, and I'll show you. So the upper lines here is these are all patients that are getting chemoradiation for their esophageal cancer. These are proton patients, and up top are the photon IMRT patients. The difference here is that these go on to surgical resection and these don't. Up here, the same thing, surgical resection and not. And you can see if you look at these two versus these two up here, there's much cooler colors than up there. The higher the color is the total toxicity burden that you looked at. And so in the non-surgical cases, protons, IMRT, you can see that there's less toxicity than there is here. And certainly there's a bigger difference in the toxicity in the patients that have surgery, much more red, hotter colors in the top compared to the bottom. And those toxicities are down in this area here. These are different toxicities that are looked at in the different groups. These are pulmonary embolisms, myocardial infarctions, pneumonia, postoperative respiratory insufficiency, ARDS, those sort of things. So these are all the postoperative complications. These are just, or postoperative adverse events rather, and these are just adverse events, chemoradiation adverse events. So these are protons, this is photons or IMRT. So you see the adverse events are much lower in the proton cases as compared with the IMRT cases. And if you look at non-surgical versus surgical, either way you look at it, the adverse events are significantly lower with proton beam radiation. So there's a growing body of evidence that shows that there's dosimetric advantages to proton beam radiation. Clinical trials have shown that there's a significant reduction in both the acute and long-term treatment-related toxicities. There's a lower incidence of postoperative gastrointestinal, pulmonary, and wound complications. There's a 25% reduction in postoperative hospital stays by using protons as opposed to IMRT radiation in preoperative treatment for esophageal cancer, but there's no improvement in local control or survival. So what's the future of proton beam radiation in esophageal cancer? Well, because we have less side effects, we could get away with giving higher doses and then leading to better local control. Because these are bioequivalent doses between protons and photons in these trials. So now that we have less side effects, maybe we can jack up the dose of protons and get better control and still have side effects less than IMRT. We can use it for recurrence. So a lot of patients, not a lot, but we have patients that have recurrent disease, so you can sneak in protons to eat more easily in patients that have recurrent disease. Or if you treat them initially with protons and need to re-irradiate, that makes it that much more easy as well, because our limiting factor in re-irradiation is the dose to normal structures. And also radiation for oligometastatic disease. That means someone has one or two metastases. Protons are great because they're very focused and it leads to very little morbidity. And so that's it. I have a fun fact, since it's Borland Groover, I found this here. People born after 1990 have 2 times the risk of developing colon cancer and 4 times the risk of rectal cancer than those born in 1950. So make sure you do your colon cancer screenings. Just an aside, I thought I'd give an ad for you guys. Anyway, that's it.
Okay, so our next talk is about more of a social aspect of liver cirrhosis, and the speaker is Dr. Daniel Kong. He joined Borland Groover in 2006 from St. Louis, Missouri, where he was an assistant clinical professor at that.
That's good.
Okay.
And I have to put something on here.
Oh, yeah.
Let me know that I just set my timer, so I promise I won't go above. That's how I did it. My mother said I never talked till 3 and then I never shut up, so I'll try to avoid that. Between the timer and my BPH, I promise we'll be out. So anyway, this is my 42nd year of being in medicine, if you include medical school, and my 32nd in GI, and was born in St. Louis, undergraduate Tulane Medical School, St. Louis University, and then everything else was at Georgetown, and my GI fellowship was with Georgetown. Can you hear me okay? No.
Turn it off.
Okay, how about that? Okay, so anyway, so 42nd year of medicine, including medical school, 32nd year of GI, and born in St. Louis, Tulane undergrad, St. Louis University for medical school, and then Georgetown was everything else. And my fellowship at Georgetown was with the VA, the NIH, and Georgetown. And back then, GI fellowships were only 2 years, and the mentors you got kind of in terms of hepatology were spotty. There was no GI, there was no hepatology fellowship, there was no hepatology certification, but I was very fortunate because some of the top hepatitis C experts in the world were at the NIH, hepatitis B, a guy named Leonard Seif at
He joined Borland Groover in 2006 from St. Louis, Missouri, where he was an assistant clinical professor at that.
That's good.
Okay.
I'd like to put something on here.
Oh, yeah.
Let me know that I just set my timer, so I promise I won't go above. That's how I do it. My mother said I never talk till 3 and then I never shut up, so I'll try to avoid that. Between the timer and my BPH, I promise, we'll be out. So anyway, this is my 42nd year of being in medicine, if you include medical school, and my 32nd in GI, and was born in St. Louis, undergraduate Tulane Medical School, St. Louis University, and then everything else was at Georgetown, and my GI fellowship was with Georgetown. Can you hear me okay? No.
Turn it off.
Okay, how about that? Okay, so anyway, so 42nd year of medicine, including medical school, 32nd year of GI, and born in St. Louis, Tulane undergrad, St. Louis University for medical school, and then Georgetown was everything else. And my fellowship at Georgetown was with the VA, the NIH, and Georgetown. And back then, GI fellowships were only 2 years, and the mentors you got kind of in terms of hepatology were spotty. There was no GI, there was no hepatology fellowship, there was no hepatology certification, but I was very fortunate because some of the top hepatitis C experts in the world were at the NIH, hepatitis B, a guy named Leonard Seif at the VA, and the guy that wrote the textbook on hepatotoxicology, whose name was Hy Zimmerman, was also at the VA. Leonard Seif, these are, a lot of this is going to be little pearls, fun things to know and tell. But anyway, Leonard Seif was studying hepatitis B, and he was doing it at the VA because during World War II, the soldiers got vaccinated for yellow fever, and that contained the hepatitis B virus. And so he had a good way of following the natural history all the way out to see how many people get cirrhosis, how many people get this, how many people get that. But anyway, so I had some great experience with liver disease, and I have an interest in liver disease. I kind of consider it the intellectual part of gastroenterology. So to get started, I thought everybody's great. Talks were great. Dr. Ackerman convinced me again why I only got a B in physics in college. I never understood the train going in one direction and something, why anybody cared. But anyway, great talk. I'm going to comment on the other two guys, gal and guy. A couple things with Dr. Racha that I'll say, comment on. One is, I'm one of those people who doesn't think acetaminophen for people with liver disease is contraindicated. Stan Benjamin, who's my chief of gastroenterology at Georgetown, co-authored a paper, I think around 1979, that was called Therapeutic Misadventure with Acetaminophen. And yes, we see these things with transaminases go to 10,000, and usually the history is fairly obvious. But it isn't as though for normal people acetaminophen is toxic. The reason it's toxic in that situation is because when you drink, you shift the metabolic pathway of acetaminophen to a different toxic intermediate. And it's more common in the amateur alcoholics. So it's Christmas time, it's holiday season. They're going out every night to different parties, they're coming home, popping a couple Tylenol. A couple hours later, a couple Tylenol, so on and so forth. It happens more often in that setting than your professional everyday alcoholics. So it is not in and of itself a couple Tylenol days that can hurt a liver patient. In fact, if the patient says to you, well, what about ibuprofen? Well, I kind of think you're better with the acetaminophen because ibuprofen, like all nonsteroidals, can affect platelet function, and they're already decreased. And, they've already got the low clotting factors, and so now when they get their ulcer from the ibuprofen, they got a much worse disaster probably than the chance of acetaminophen doing something to them. A couple other things from his talk. This was when refer to GI. I'll try to keep to that topic. There's two things you definitely don't need to refer to GI, at least not most of the time. Again, as Dr. Liu talked about, statins are probably safe most of the time. It's counterintuitive because they got the fatty liver, they got the enzymes going up, you think better stop those, when in fact may make the fatty liver worse. So hardly ever do you need to do that. The other one is Javarez disease, aka Gilbert's, which is congenital benign indirect hyperbilirubinemia. So if your total bilirubin is 2.8 and you do the fractionation and indirect is 2.4, you got it. That's it. Now the only other thing that can really cause indirect hyperbilirubinemia is hemolysis. And that's usually fairly obvious as well. The patient might be a little anemic, and then you do the other stuff, haptoglobin, so on and so forth. And only once in all these years did I diagnose G6PD deficiency, which was leading to premature hemolysis and indirect bilirubin. Okay, remember, tell the patient, how do you talk to the patient? Okay, every day red cells die, and when they die, they release hemoglobin into the bloodstream. Hemoglobin goes to the liver, where it's converted to bilirubin. Bilirubin has to be hooked up to a chemical to let it be water soluble, i.e. peed out in the urine, and that process is called conjugation. And there's a lot of us from word go, congenital, who are just slow conjugators. It doesn't hurt you. I once had a 20-year-old since I've been in Jacksonville who was trying to get in the military. The military wouldn't take him because of this diagnosis. And again, I, fortunately for me, or maybe unfortunately, was never a vet. But there's that old thing about military intelligence, so they wouldn't let this kid in, no matter how much I told them that he could go there. Anyway, so those are two things. You can almost always diagnose that. And now, how high can the bilirubin get and still be Javarez? Usually in the 3 range, unless they've also got something else going on. Renal disease might make that the case. Patients come into the hospital, they're fasting, maybe they get other medications. So there's situations like that. But generally, it's not going to be 10. Okay, it's going to be well under 5. So that's those 2 things about that. Let's see here. A couple other things about medications that can cause fatty liver, most of which we don't see a lot anymore, but valproic acid, minocycline is a famous one. And probably the most common thing to think about is prednisone. Steroids cause fatty liver, and that we use all the time. So, a patient comes in, they got fatty liver, you don't look fat to me. You're not diabetic. But, oh, by the way, you're on prednisone for your COPD or your asthma or whatever. So a couple things there. As far as medications that produce toxicity to the liver, specifically, I think Dr. Wu talked about this. Hold on, I got to have my glasses. Let's see if I can do this while I'm pulling the thing off. Okay. So anyway, diclofenac. I've seen bilirubins of 12. So that's one that if you got a bunch of choices in non-steroidals, maybe you think about not giving. And the other one is augmentin, she talked about. And again, it's the sulbactam part of the augmentin that causes that. And I certainly have seen that, and I have treated it with steroids and had a favorable response, but it often takes months to go away. Okay, so let's see, what else was I going to tell you? So this, right on your sheets that you're going to fill out and sign, this is not evidence-based, okay? I'm kind of a curmudgeon. I think evidence-based medicine's great, but it's crowding out the art of medicine. Part of the art of medicine is talking to patients in their terms, okay? So you can check off right now it wasn't evidence-based, because it's all about what I've learned over all these years. Anyway, so let's see, you got my slide? How do I do this? Most of what I have on these slides has already been kind of talked about by the others. Can I do it from here because I can't see there?
You can do that.
This, or is there something here?
You can do it from here. Yeah.
Okay, good. All right, so cirrhosis, I just gave you the dictionary definition because patients don't know what that means. And one of the reasons I think it's important to be able to talk about this is because right after cancer, there's cirrhosis, there's heart failure, and there's kidney failure. And, those are the top things patients hear that they think I'm dying, right? So, what is cirrhosis? I tell them it's a scarred liver. As Dr. Liu said, you cut your arm and you get a scar, that's fine. But if you wind up with 80% scar liver and 20% good liver, then you get to the point where the liver can't do the things the liver's supposed to do. And you also start to have what I like to call plumbing problems, which I'll go there the other way. Okay, here we go. All right, so we've already talked about the causes, and this is roughly the frequency: alcohol, hepatitis C and B, steatohepatitis, aka NASH, aka NAFLD, aka fatty liver. One of the things over all these years the academicians like to do is change up the names so that you have to learn it, what they're talking about. Neurologists, of course, are famous for that. Anyway, and then there's hepatitis, autoimmune hepatitis, PBC, formerly primary biliary cirrhosis, now to be politically correct and not scare patients, primary biliary cholangitis. They got to keep the monogram anyway. And then hemochromatosis, and I think Dr. Liu might have mentioned, ferritin in and of itself can be elevated with lots of liver diseases, especially acute alcoholic hepatitis. So it's in that setting that you really need to know the iron saturation, the total iron, etc. And hemochromatosis is, of course, a disease that you really don't start seeing until later in life when enough iron has accumulated to start affecting various organs. So you're not going to see it generally in people in the 30s, but somewhere in that time frame is where it starts to happen, and of course it affects lots of different organs. Rare is Wilson's disease, alpha-1 antitrypsin deficiency, and I think a few others. So how's it diagnosed? We already talked about that. Really, most of the time you don't wind up doing a biopsy anymore. You've got these various scans. The MRI with elastography, and I'm sure they have this at Mayo as well. The MRI can tell you the percent fat in the liver. Again, normal is less than 5%. Up to 30%, interestingly, is considered mild, and then you go from there. But it does give you a number for a patient, and it's something you can follow very well. Again, they lose 30 pounds, suddenly they go from 30% to 5%. And this elastography thing tells you the fibrosis score. 0 normal, 4 cirrhosis. Fairly reliable. I've had patients that have gone from F3 to F2, and of course you kind of think of scar tissue as being permanent. And, it sounds good to be able to say to the patient you've had improvement, but I'm always not sure about whether that's true or not. So, simple talk. What is the purpose of the liver? Remove toxins, metabolize medications, synthetic function, the ability to make things, going back to if you only have 20% liver and the rest scar, the scar's not doing anything. So that is where you start to get into problems. And then portal hypertension, which I explained subsequently. Toxin removal. I focus on ammonia. Ammonia is made in the gut from protein. Everybody does it. When it gets absorbed, it goes to the liver detoxifies it. And if it can't do that, because again, there's not enough liver to do that, then it can cause anything from sluggishness to forgetfulness, all the way up to coma. I haven't seen coma probably since I was in training at the VA. But one of the little pearls that I was taught, I don't know if I've ever had a patient do it, is, if you're trying to figure out if your spouse maybe has got a problem, have them get color by numbers book at the drugstore, connect the dots. If they can't connect the dots, that's a pretty way of picking up subtle problems, okay? And one thing that comes into play with ammonia is the patient who's the school bus driver. How far involved do I get with that and the liability and the so on and so forth, because I don't want to be the one that has to say, you don't have a job anymore. In fact, you shouldn't even be driving a car. And again, it can be very subtle. So anyway, all right, so how do we treat that? Well, we give them lactulose, right? Lactulose changes the acid-base status in the colon, traps the ammonia, out it goes. Again, patients don't like it. It causes gas, bloating, and diarrhea. And because it causes diarrhea, often they think that that any laxative will do. They think that's what the therapeutic mechanism is. But it isn't. It's changing that acid base. And in actual fact, you try to give it to them until they have diarrhea, and then you just back off just a little bit. Okay? Doesn't always work, and again, they don't like it, and probably part of the reason it doesn't always work is because they don't, they're non-compliant. They don't want that. Xifaxan is the other treatment, otherwise known as rifaximin. It remains very expensive. It's hard to get insurance companies to cover it. Certainly, they want you to do lactulose first. Sometimes they'll then let you add it if lactulose isn't working. It works by reducing the number of bacteria in the bowel. It's non-absorbable, to reduce the production of ammonia. So you kind of got a dual mechanism of how you're trying to treat it. And again, it can be difficult to get them to pay for that. All right, so portal hypertension. I like to call it a plumbing problem. So you've got this major vein, the portal vein going into the liver. It drains the spleen, it drains the gut, and when it goes into the liver, it breaks up into little capillary type things called sinusoids. And like the rest of the liver, there's scar tissue around them. And so as that's trying to come in, it's meeting increased resistance to flow, and the liver acts like a sieve, and fluid literally weeps off the surface of the liver into the abdominal cavity, which is called ascites. Now, of course, at a much higher level than what I want to go into with patients, there's other reasons like low serum albumin, which holds the fluid in the vascular tree, and like the renin-aldosterone ratio, that's more complicated than I ever want to know. But that's where things like spironolactone fit in along with Lasix, okay? So, let's see it. I'm going on to the next page here. I did somewhere here. Okay, yeah. So portal hypertension is a result of increased resistance to flow. The other thing that happens besides the ascites is the blood that's trying to get through there is going to take the path of least resistance, and that path of least resistance is through veins that ordinarily exist in your stomach and your esophagus. And in the esophagus, they're there, but they're little thin-walled creeks, and now they become torrent rivers, and they aren't used to carrying that kind of pressure, and they rupture and bleed. And that, of course, can be one of the ways that people die. I haven't quite seen it as much in recent years as I once did, but anybody who's been around for a long time, there was, the Blakemore tube. And you had to have a helmet and tie it to it, and, patients could die, and the whole thing was a mess. But anyway, so we don't see that quite as much anymore. We used to inject sodium moroate, which scarred the veins into it for the last 20 years, probably, I guess. We have been putting rubber bands on them, which is fairly effective if you can actually see the blood. The esophagus is full of blood. So if you try to do that, and again, I equate varices to varicose veins in the legs. Most patients know about that. May or may not be kind of exactly the same, but they get the idea. And let's see, we'll quick with that. So going back to, they ask, what is the treatment? What is the prognosis? Can I have a liver transplant on Dad who just came in with his handle of vodka a day? Because everybody in the United States gets to have everything, So how do you treat ascites? Paracentesis, which is really not a very painful process. We used to do it. It was a very painful process for me because it would take sometimes an hour or more, and you're sitting there filling up the thing. So we gave that job to the radiologists who give it to their underlings. But it can have side effects, I kind of was taught you really don't want to take out more than about 5 liters. I've seen 11 liters be taken out. Part of the way you can counteract some potential issues there is by giving them serum albumin. And many studies along the way, yes, no, yes, no, yes, no, just like pioglitazone and just like vitamin E. Vitamin E was going to be for fatty liver, but then it turned out people died from it, but then so we don't want to do it, but maybe not all people die from it. So back and forth, back and forth, back and forth. But anyway, certainly in hospitalized patients, I usually do order albumin and try to get it done as an outpatient as well. Because the side effects are you remove too much from it, again, talking in patient terms, the fluid you're removing rapidly refills from the vascular tree, from the bloodstream, and then your blood pressure goes down, and then your flow to the kidney goes down, and then your kidney blood tests start to go up, and therefore you have to be careful with that. In addition to which, you can have infection, probably not so much with everyday paracentesis, but down at the bottom I talk about drainage catheters here. And the treatment for the patient is a low-salt diet. It doesn't make any sense to be taking these diuretics and eating a bag of potato chips a day because water follows salt. So you have to explain that to them, and sometimes you have to limit the fluid intake. Usually that's when you start to have problems with hyponatremia. You're on the diuretic, sodium's down to 128, 126. That's probably the major reason you wind up having to limit the fluid from 1,200 to 1,500 cc's a day, all told. And again, diuretic therapy, the idea there is get the fluid to mobilize from the abdomen, and then you pee it out. One of the ways a patient can know whether that's about the right amount is a couple pounds a day. You shouldn't be losing probably 5 pounds a day, but people can lose a lot of water and a lot of weight fairly quickly. And again, it's important for them to recognize that as you do that, you can wind up having the kidneys think that you're dehydrated because you're taking all this water out of these other places. You got total body water overload, but it's not where it should be. So you got to be careful with that. Or of course, you can go into hepatorenal syndrome where everything shuts down, and that's almost always deadly. you have to worry about sodium and potassium. So one of the things I get after my patients, they need a refill of Lasix. Well, when do they last have the re-MP? Because that's the main thing I'm going to worry about. Let's see. Pearl that I learned years ago, and it's paid off pretty well for me, is you can be pretty cavalier, especially in inpatients, when they've got peripheral edema, lower extremity edema. When that starts to go away, that's where you're getting to the point where you really got to watch the diuretics in terms of you don't want to get hepatorenal syndrome, which is one of the ways that happens. So let's see. Peritoneal catheters. There was a hospitalist, I don't think she's here, at Baptist South who was very keen on getting patients out of the hospital. And every single one of these patients, she wanted me and my partners to put not a tank off, the Chlorex catheter in that patients go home with. The hospice place. If it's hospice, that's great. They're going to die anyway. But if it's home or a nursing home, you got somebody who's relatively non-sophisticated draining this thing. And, I have a patient right now who's had one for about 3 years, and he went home with his mother, who's kind of a dominatrix, and she doesn't. She got under control, and he stopped drinking, and, he's done great. But people tend to get infection, they drain too much, they go into the whole hepatorenal syndrome, so on and so forth. So I think it's kind of a fairly risky thing to do. Let's see. Okay, so we talked about lactulose and Xifaxan for encephalopathy. Think about this. If it's not working, why is it not working? Are they consuming too much protein? It's been said 60 grams a day for a protein diet for liver patients, but not necessarily, because, of course, you're trying to get them, one of the ways they die also is they have muscle wasting, right? Going back to what happens to fatty liver patients. By the time you get them, the fat may be gone because they're already at that point where they've, mobilized every energy source they have. And, of course, they get peripheral muscle wasting and so on. So you can think about that. Sometimes electrolyte imbalance will contribute to it. Certainly a GI bleed will contribute to it because blood is protein. And so you get your upper GI bleed, it's coming downstream, your protein and your ammonia is going to go up. And then, of course, think about the fact that patients don't metabolize things normally. So are they on any benzodiazepines, any narcotics, any other psychotropic type drugs that may be causing their confusion, not just from ammonia. Treatment of varices, again, emergent scope and banding, and octreotide drip. They don't need to know any of that, the patients, that is, in the hospital. Beta blockers reduce portal pressure, and I'm not as up to date as Dr. Liu, for instance, but as far as I know, we don't yet prophylax with bands. True or not? Yeah, maybe, maybe not. I wouldn't because, well, I will tell you this. My very first year of practice, I'm not that busy. I'm following my partner around who's 2 years older. And he has a kind of a famous guy locally in St. Louis who has alcoholic cirrhosis and had come in with bleeding varices. And now he's bringing him back a month later, and this is when we injected him for his, next stage. You had to do this in sequence till you obliterated him. Well, he sticks a needle in the guy, and the guy bleeds like stink, and, never left the hospital alive, let's put it that way, which gave me a healthy respect for you don't poke a skunk, and don't break it if it ain't, don't fix it if it ain't broke yet. But I'm sure you could think of that both ways.
Your classic answer is correct.
Yeah. So, anyway, but that's what you do with that. If bleeding is not controlled acutely, then you can do TIPS. Now, I saw two wording for what that is. One was transhepatic, one's transjugular, but it's the same thing. You go through the jugular vein, put a catheter down in the liver, and basically put a stent in there that creates a superhighway, so that all this, resistance to flow that's going up into the varices and so on and so forth now passes on through. But because it passes on through, the liver has even less of a chance to see that ammonia, and then ammonia levels go up. So that's probably one of the major side effects of doing a TIPS, is that you now have to deal with encephalopathy. And as we talked about, there's treatment for that, but it's not always as effective. And so patients need to know that before they do a TIPS. Let's see if I'm staying on time. I don't know, my bladder tells me we are. But anyway, all right, so what's the prognosis? Well, obviously, if you can stop the damaging process, that's going to be helpful. So alcohol is the most obvious thing you can stop. And a lot of patients actually will. And patients who do, I've had lived many, many years. I mean, you'd look at their blood test, you would not know they were cirrhotic, but you look at their CAT scan, and sure enough, they are. Hepatitis C, of course, can now be cured. Hepatitis B can be treated. Hemochromatosis, phlebotomy, autoimmune hepatitis, azathioprine, low-dose prednisone, PBC, or sodiol, which is a fairly benign drug, and of course we steatohepatitis. I am up, oh my god. Anyway, so weight reduction, again, we'd all be skinny if that was easy. What's the prognosis? Variceal bleed and ascites, both indicators of poor 5-year survival rate. Which goes back to when you're talking to cancer patients. There are things that have a much worse prognosis than cancer. You never want to take hope away. I was taught that early on in my career, okay? Especially with oncology, but in this case too, you got to give the patient the idea that if they follow along and they do what they're supposed to do, they have some chance of a prolonged survival. But uncontrollable GI variceal bleed is, of course, something that kills you. And you have low platelets, poor clotting, so on and so forth, intractable ascites, liver failure, including jaundice. That's that acute alcoholic hepatitis patient coming in with a bilirubin 26. They're the ones that often don't make it. And of course, liver cancer, which was talked about, and ideally you should image them every 6 months, at least with ultrasound. MRI would be desirable, but if you can get the insurance to pay for it. And of course, going back to liver transplant, they all want a liver transplant, right? Well, maybe, maybe not. I'm sure that you are familiar with the term MELD score, but if not, it's a mathematical formula that allows a liver transplant center to decide, are you getting near? And it doesn't always correlate because, for instance, let's say you have a variceal bleed. There's no part of that formula that includes that, which can be life-threatening, but at the same time, I think the idea is the numbers that go into that formula, if you're having a variceal bleed, they'll probably be bad too. And the one thing I wanted to talk about that was, I don't know how many in this audience know who Mickey Mantle was, but he was a famous baseball player. And he was an alcoholic, plus he had hepatitis C, and in 1995 or so, he got a liver transplant, and he had cholangiocarcinoma. Well, about 3 weeks later, they found out on his CAT scan of his chest or chest x-ray, oh, by the way, it's metastatic there. This is what really led to this MELD score, which was originally called the Mayo. MELD is model for end-stage liver disease, but they call it Mayo, but then the Mayo people decided, well, more people would use it if they didn't make it theirs. So it became the model for end-stage liver disease, but it happened because of Mickey Mantle, because he was proving they had enough money, you could do it. When I was at Georgetown, we had Shaw's and everybody come over and get kidney transplants. Got really nice suites and everything. So that's why it happened, that they came up with that. So this way, it doesn't matter if you're on a list for 2 weeks or 2 years. The first available liver goes to the person who it matches, who's got the worst score. And again, usually that's about 20, but that may be changing. Alcoholics, again, I know Mayo, at least last I knew, wants you to be sober at least a year. Some places 6 months. I don't know, I saw a reference to some article that says there are patients who do well even in 2 months. But that all goes into it, and whether they got a good social setting, support, so on and so forth. Let's see if I had anything else I wanted to tell you. So final point, cirrhosis is not hopeless, depends on the cause, depends on the patient cooperating, and the problems to avoid are overdiuresis, alcohol, and hepatotoxic drugs. And that's it. Thank you.
Thank you.
And I can't see very well either.
Thank you, Dr. Kong.
You're welcome.
So now we'll take our first break, and feel free to visit our vendors, and we'll meet back probably in 15 minutes around 10:30.